said, understanding my audience here, medical practitioners, I wanted to back up and recall the early and the consistent role that the medical community has played in tobacco control. From the medical doctor being the first to chart the meteoric rise in lung cancer and then correlating that rise, or showing the causation to commercial cigarettes. And then as shown on the slide here, how the tobacco companies have held up medical profession as the beacon of the community, as societal pillars, and really showing how the tobacco companies rely on community norms in terms of marketing their product, and they know how effective and important it is to have a product that is interwoven into the fabric of the community and society in order to be widely used. And doctors have been, unfortunately, and in a rather twisted manner, the face of that acceptability. So it's also appropriate, doctors can play a role in countering that. And this has been led in part by our nation's doctor, the Surgeon General. Surgeon General has played a great role in presenting evidence and underlying foundation of tobacco control. And I'm going to present a busy slide, has a long list, incomplete list of many reports that the Surgeon General's office have introduced over time. And I present these not to be familiar with everyone, but just to highlight that policy change often begins with medical research and underlying research and forming an evidence base for the policies. And these reports have focused on both the extensive health risks of using tobacco products, the drivers of tobacco use. They've touched on cessation, effective cessation strategies, and they have looked at subpopulations, including youth. So we can see that, going back to that Surgeon General report, it's really had an impact, that 1964 report, and many of the policies that we're going to talk about today at federal and state level have relied on the sound foundation that have been conveyed in the Surgeon General's reports. And so some of the examples from the federal level, these policies that have been spawned by the Surgeon General's reports are included on this list. These are going to be some of the big tobacco controls we've seen come out at the federal level. I'm going to talk to you more about the state level ones today, but these really illustrate a lot of the effective policies that state and local communities can build on, expand upon in some cases, and really all these policies work together. So without reading the specific federal policies, again, we're looking at policies that touch on what we refer to in the tobacco control community as the vaccine, the tobacco control vaccine. So federal policies we just saw and some others that we're going to get into really touch on what we know works. We know it matters where tobacco products are used. We know it matters how tobacco products are priced, that there's support for cessation, and that there are powerful media campaigns. And these all come together to form a comprehensive program, and that comprehensive program is successful because it helps form a tobacco-free norm in the community. So with that, we look at Massachusetts policies over time. And in 1997, we saw Massachusetts pass a bill, no smoking in the State House. At the time, I'm sure it seemed vanguard. Looking back at this state, at this juncture, hopefully we can yawn and be surprised it took so long. In 1998, advocates in Massachusetts worked to defeat a restaurant association bill that would have lowered the threshold for smoking regulations and prevented local authorities from passing tougher smoke-free restrictions in the restaurants and such. So that was a victory in 1998. In 2003, many cities and towns, they passed and have sustained smoke-free workplace regulations. Those included Boston, Cambridge, and Somerville. And as so often is the case, this local advocacy and action and success really helped enable a statewide action. In 2004, the state passed the workplace law, 100% smoke-free workplaces, which gave significant coverage, and made a safer work environment for employees throughout the Commonwealth. In 2011, that was extended to casinos. Massachusetts casino law ensured that gaming facilities were 100% smoke-free. And in 2014, Tobacco Free Mass supported a lot of college campuses with their smoke-free policies. So these are some fantastic landmarks in terms of regulating where tobacco use can be used. So not only is there the direct health component, but also, of course, the norming that I'm referring to. There are always being mindful when we talk about policies about whether and which groups might be left out. So when we think about use policies, people who don't work indoors, that's still an area to think about. And then multi-unit housing are some of the vulnerable populations, people who are reliant on their neighbors to do the right thing. 2018, in terms of federal housing, there was a 2018 rule from HUD that required PHAs, public housing authorities, to implement smoke-free policies. So one of the other policies showed in the vaccine are price. That's another important, moving on from use, are price policies. And likewise, that can be a pro-equitable policy if done correctly. So we know that there's a strong relationship, inverse relationship between the price of tobacco products and use of tobacco products, as the table on the right indicates. And in 1992, as far back as then, Massachusetts, through a ballot initiative, had a 25-cent tax per pack of cigarettes, and they dedicated a portion of that revenue to create the Massachusetts Tobacco Control Program. So combining some of those inoculants, we had both a price increase and funds for campaigns and educational services. In addition to federal tobacco taxes, the 1998 Master Settlement Agreement was one of another policy that really helped keep the prices of at least cigarettes high. And we saw how successful with the MSA, the required fees that got tacked onto the prices, as well as state and federal taxes, that has been very successful. In 2002, Massachusetts added a 75% cigarette tax, so an increase of 75 cents, and worked in partnership with healthcare access advocates, funding health insurance for children and a senior pharmacy benefit. And then in 2008, there was another $1 per pack cigarette tax increase, again, working in partnership with healthcare access advocates and dedicating the revenue for health reform. So these have been great initiatives in Massachusetts. There are some more recent ones, but for the very recent Massachusetts laws, you're going to hear about that from our next presenter. So I'm going to leave some of the most recent laws to next. But it's always important to, again, mention where there might be room to consider related policies that improve upon it. So there are ways that manufacturers undermine price increases, and that's including price promotions, coupons, and the like, and also by creating and moving their products to just be different enough to change the definition of whatever the tax applies. So if the tax applies to cigarettes, they may create a slightly different product and try to evade it. So we're just always mindful of those when we're thinking about our policies. So in addition to price, and we know that as the price goes up, that really contributes to the tobacco-free norm as the rate of use goes down. But for all its success, the companies, of course, will react and counter this tobacco-free norm with other types of marketing. So there's other P's we sometimes refer to with product placement and promotion, adding on to price. And these all, again, help destroy the tobacco-free community norm that Massachusetts advocates are seeking to establish. So the Master Settlement Agreement that I touched on for price has done a really great job of illustrating how powerful marketing is and how powerful policies that can restrict exposure to that marketing or the marketing itself can be. In 1999, another state law worth mentioning, so just following the Master Settlement Agreement, the state committed tobacco settlement revenues to public health and tobacco programs. And in fiscal year 2000, of course, it's distant memory now, over 22.8 million from the MSA state revenues was put into those tobacco control health programs. We know that there's been some problematic use of those resources, the MSA funds in the future. But the point that we're really making here is that the MSA had a lot of marketing restrictions, reducing the youth exposure and all of our exposure to products by restricting the tobacco products and where and how they could be marketed. So looking at how that is translated into non-Master Settlement Agreement laws, we know that there is work to be done and that Massachusetts continues to keep its eye on the prize and build those tobacco-free norms and reducing exposure to the marketing that is so problematic and that drives use. Two laws that are not exactly on point, but I'm going to mention at this point. In Massachusetts in 1996, Massachusetts was really ahead of the game, and 1996 law requires that companies report their product ingredients and their true nicotine yield ratings to the Massachusetts Department of Health. That was called the Tolman Disclosure Law. And that's a really interesting law because it comes into play now as federal regulators look to understand how nicotine and what levels of nicotine might be an effective policy for product manufacturing standards. So Massachusetts, I think, may be the only state on the books with that disclosure law and can be good information for regulators. In 1997, Massachusetts became the first state in the nation to divest all state pension fund holdings in tobacco stocks. And while that does contribute to the community tobacco-free norm, it's a little outside the scope of the marketing that we most see, but it's really just making a statement that tobacco is not part of the community and the messaging that we want to send. But there are products out there, and the way that those products are marketed, that there is room for Massachusetts to work on, and we do see, I have this here on that right-hand side, we know that there's a lot of marketing and it gets a lot of attention right now online and influencers and things like that, but really the retail environment is where most of the marketing happens still today and where Massachusetts is focused. So we do see throughout Massachusetts local initiatives to license and reduce density and density of tobacco retailers and the accessibility of products. And so that's happening at the local level, and there's talk at the state level and lots of opportunity for involvement. The reason why the retail environment is, and the marketing and the sales of tobacco products are so important to those of us who are involved in state and local level tobacco controls is in part because that is what the federal law authorizes the states to primarily focus on. So sales and marketing of tobacco products, that's where state regulations can dip in, and those can be extremely effective since we know that the marketing of tobacco products drives use. So just very quickly, the final, one of the final inoculants are cessation access. And I have on this slide a list of numerous laws that Massachusetts has passed to ensure that there is more equitable access to cessation support. You'll hear about some more recent ones as well and some future initiatives. But these are really critical to fight this addiction. We need equitable and even access to cessation products, especially to counter, with all the marketing that's going on. You have people struggling to quit and need support that is covered through their medical access. And then finally, media campaigns. Those have been shown when done well. They can be very effective for reducing initiation and promoting cessation as well. Of course, this requires funding. Media is a pricey initiative. So with that, I will close and turn it over to hear about some more recent legislation. If there's questions, I'm willing to take them at any point.
Thanks so much, Ilana. We appreciate it. And just for folks to remember, you can type your questions for Ilana and any of our other speakers into the Q&A box for the end of the presentation. So with that, I'm going to turn it over to Gwendolyn Stewart, who is the Director of Tobacco Free Mass. Gwen, you can turn on your camera and your mic whenever you're ready.
Thanks. Hi, I'm going to try to share my screen. And let's see if I can get that going. Is that working?
You're all set.
Okay, great. Just get a different view up here for myself. Okay, so I'm here to talk a little bit about the victories and opportunities. And basically, I want to applaud Ilana for capturing decades of tobacco control history in a very brief moment. And she kind of what she talked about shows the interplay between the federal government, the state government, and local. And so I want to just also give a shout out to talking a little bit about how in Massachusetts we think about policy change. And one of the things that the state is able to do is help educate the local municipalities. So cities and towns can pass policies that then we build on at the state level. And so there's a huge interplay between local public health and the state public health infrastructures. So I just wanted to kind of mention that. So the recent victories we've had, again, really built a lot, in a large part, build off that the local victories. I'm going to talk a little bit about the Youth Tobacco Prevention Law that was passed in 2018, the increased funding for the Massachusetts Tobacco Cessation and Prevention Program, and the Act Modernizing Tobacco Control, which just passed last year. So let me start with the Youth Tobacco Prevention Law, because this one was, you probably heard about it as the Tobacco 21 law. And that was really where the hype was. That was the easiest thing for the public to understand, for legislators to understand. It raised the age of the sale of tobacco to 21. It had been 18 statewide, but what had happened was that local municipalities, cities and towns, were passing age increases so that a lot of them already were at 21, and this built the momentum. And the same thing with banning the sale of tobacco in pharmacies. To the point where CVS at one point finally couldn't sell tobacco in most of Massachusetts because of local legislation. And so they ended up just deciding not to sell tobacco at all, which was huge because that impacted beyond Massachusetts. But then also, there were pharmacies still selling, so Walgreens and, and other ones. And some of them, sadly, were some of the worst offenders to selling to minors. So, so this tobacco prevention law in 2018 also banned the sale of tobacco in any healthcare establishment, including pharmacies. But really, pharmacies were the last holdouts there selling it. And it also banned the use of e-cigarettes, vapes, where smoking is not allowed. So it banned the use of e-cigarettes in restaurants, bars, workplaces, anywhere that the statewide smoke-free workplace law applied. And again, a lot of these policies had already been passed locally in many of our communities. And so this was a huge reason that this got the momentum and was able to pass. And so we called it at the time like the omnibus bill, which sounds very impressive, because it felt like so many pieces together. And it was very important. A lot of these places in the state that had already done these policies and protected young people, but then there were a lot of places where young people were not protected. So it's really important to make it a state law and to tighten it up that way. And it's important to note here that one of the things that the law does not do is prevent municipalities from going stronger on these things. So we are very, very conscious of advocating for when we advocate for legislation, making sure that we do not preempt the local municipalities' ability to make stronger laws. And that's one of the things that we guard against constantly, that there's never preemption of local ability to do stronger laws or to work on their own tobacco policy. So that was an exciting, huge victory. We were thrilled. And then at the same time, we were able to increase funds for the Massachusetts Tobacco Cessation and Prevention Program. And so let me just sort of review what this program is, because first of all, the name is outrageously long. It used to be called the Massachusetts Tobacco Control Program, but that doesn't really reflect what it does. It promotes cessation, helping people quit, and it also helps prevent young people from starting. It also, of course, works on secondhand smoke and all those other pieces. The way it works is it funds the local boards of health to promote and enforce local tobacco laws. So those are those local policies that end up spurring that statewide change. It allows municipalities to try out new policies that then we see if they're going to be a positive impact, make a positive impact, because the program also does evaluation. And so they can see how those policies impact their communities. So cessation education and services, including the Quit Line, the Quit Works, any of those pieces that you hear about, communications campaigns, try to stop, quit now, any communications campaigns that come out of the state are from MTCP. Youth prevention, you may or may not know of the 84 movement. It is a program by MTCP, the tobacco program, that it does not fund programs, but what it does is it supplies them with training so that they can go into their own communities and advocate for real change. So these are young people who, they might do a poster at their school and kind of educate their peers. That's part of it. But what they're also doing is going in and saying, hey, I want to get flavored tobacco out of our town. Here's the impact that Jules have on my friends and me. They go in and they talk to their local boards of health, their city councils, their mayors, whoever is in power and can make the change, and they educate them on policy changes. So they have a real impact, and we've been amazed to see the way they've reacted, and we've had young people who have gone on to be interested in public policy after seeing how they've changed their communities. So evaluation and epidemiology is that the last piece of this, of what the program does. And so they're the ones who keep track of smoking rates, who have done amazing research looking at where the tobacco industry is pricing menthol cigarettes, higher or lower, city block by city block, very revealing. So all of those pieces help inform public policy, and they help us know what's working, what's not, and where we should be spending our efforts. So this is the Massachusetts Tobacco Cessation and Prevention Program. This is a state program. This is the one that you heard Ilana talk about when that first 25-cent tobacco tax was passed. It created this program way back in 1992-93. And it's run through the Department of Public Health, a very busy department right now. So it has had mixed funding over the years. Started out in 1994, the first fiscal year where it was funded. with, that's millions up there. So that's with 50 point whatever $million. And then, you know, of course, kind of get cut off a little bit. It hovered between, you know, over 30 million. And then, and those are in that day's dollars. I didn't change it to be today's equivalent. And then you can see the master settlement came in and money came up, and then the rapid decline. And then in 2003, the funding was basically decimated. There was more funding back here during one stimulus time, but essentially it has remained flat. And this I did not do a great job with this chart because you can't really see. It's actually a slow drip decline of funding over 10 years. You know, 20,000 off here, 40,000 off the next year, drip. And what happened, though, that's important to know is that during the time where there was a ton of money, they tried everything. They tried basketball tournaments for young people where they got fats called hot shots. You know, they tried, you know, fancy TV commercials that you probably remember if you were around then back here. And, you know, they tried a little bit of everything. A couple of the things they tried were, and the thing that was most important was funding local boards of health to do tobacco outreach education and to work on policy change. That turned out to be incredibly cost effective and incredibly impactful. So that infrastructure was kept when all the money went away. And just bare bones skeleton, but it was enough of an infrastructure that it was able to be ramped back up. And that has been the backbone of this program ever since. They also did not eradicate the evaluation piece of it, or it's the surveillance piece. So that has also been a steady, you know, communications has been not nearly as well funded as before. So, but, you know, so looking at this chart, you can see how a well-funded program, you know, how well the program was funded before. It's not well funded now, but in the last couple of years, we've managed to increase funding by, you know, a few $1 million. So at this point, we're up to 6.6 million for this current fiscal year. And so that's a huge victory. And a big part of it is that what MTCP had been doing started to be understood by the legislature when they started hearing more about the role of flavors, and they started hearing about, you know, the new wave of products out there, and started understanding how the local programs would go in and work, and how MTCP kind of orchestrated that. So that there had been for a while a feeling that the tobacco problem was solved, and I think at this point that realization is it's not quite solved yet. And you'll hear a little bit more from our next speaker on some of the impacts that the continuing crisis of tobacco use has had on our state. So this is the most recent piece, the Act Modernizing Tobacco Control. And so this, I'm just so excited about this piece of legislation. It did, you know, we thought the last one was the omnibus bill. This thing was amazing. It banned the sale of all flavored tobacco products in Massachusetts. So that includes all menthol cigarettes, all wintergreens, you know, snuff, all and all flavored vapes. So that means that you cannot buy at this point a mint jewel in Massachusetts. That already happened. The flavor ban for e-cigarettes and vapes has already gone into effect. Menthol cigarettes and all of the other flavored cigars that ban goes into effect on June 1st. It also mandated cessation coverage. Most insurers were already paying for several tries using medication and counseling. This took away the copay that you would have to pay, which doesn't sound like a big deal, but for some people it really was just another hurdle. And so this does simplify it, and it helps people get access to cessation for free. It also taxed vape products, which sounds crazy, but vape products were not taxed in Massachusetts except for sales tax until this passed. So that was a huge victory too, because as you saw from the chart Ilana showed you, every time you increase the price of a tobacco product, you decrease the use, especially among young people. So this is a huge, huge revolutionary thing. I want to also sort of mention the fact that when our pharmacy ban passed, we kind of you didn't hear a huge, big triumph about it, but we were the first state in the nation to ban the sale of tobacco in pharmacies. We are the first state to ban the sale of menthol tobacco products. We're the only state still that bans the sale of all flavored tobacco products, including menthol. So that's kind of a big deal. I'm pretty proud of ourselves. And so that, again, the last phase of this goes into effect on June 1st. So the opportunities for advocacy, again, funding for the Massachusetts Tobacco Cessation and Prevention Program, it's important to know that that's the entity that does do all of the enforcement and education for the new flavor bill, the flavor law that was passed. So they're going out, currently right now they're doing a lot of letters and flyers and phone calls, but they're going out to retailers and talking to them about what to expect on June 1st, making sure that they've sold down their stock, that they're getting rid of it so they don't have it. And they're also the ones who will go in on June 1st and, fine people who haven't gotten rid of it and who are selling. So they're the ones who make sure that our laws are effectively implemented. So they're really, really important. And it's a major reason why our smoke-free workplace law worked in Massachusetts is that program. So funding for MTCP is especially important right now. And so we're really going to be pushing to keep the level funding from this year of 6.6 million. And so that's one of our biggest pushes right now. We would love to increase the tobacco tax. Again, the vape tax passed, but a cigarette tax did not, and a cigar tax did not with that last piece of legislation. That's really important to keep the price of cigarettes high as young people start looking for something else when vapes are less attractive. So we need to make sure that we keep that price up, make it a little less attractive to them, a little less attainable. Right now, not the time. We're going to keep revisiting and seeing when there's going to be an appetite to work on a tobacco tax. It might be 6 months, might be a year, might be longer, we're not sure. But the minute we feel like the time is right, we're absolutely going to be working on that, because as you know, tobacco taxes, increasing the price of these products, it's very effective, especially among young people. So, and then one last piece on here is that the local policies are something that you can look into. Find out from the Board of Health in your town. Do they have any tobacco policies they're looking at now? Are they trying to tighten something up? Limit the number of tobacco permits in their town, anything like that. How can you get involved on the local level as well? So that's pretty much it. Those are the opportunities for advocacy. And anything big that comes up, I know that Jamie has been great about sending information out. So anything that comes up in the near future, you'll definitely hear about from her. And that's it.
Thanks so much, Gwen. I'm going to ask you to stop sharing your screen so that our next speaker, Dr. Lester Hartman of Westwood-Mansfield Pediatric Associates, which is part of Boston Children's Pediatric Physicians Organization, can welcome us into the final part of our presentation. Lester, the floor is yours.
Thank you. And I'm trying to get my screen up. Present. All right. Is that working?
So you just go into presenter mode.
Yeah, I'm trying to put, presenter. Yeah, I tried to put it in presenter mode. Oh, why I'm pushing the button and it's not doing it. Share, yeah, presentation. I pressed present before. I apologize, everybody. I seem to be having some trouble.
I have your slides. Would you like me to share mine?
Yeah, why don't you go ahead and do that then? Thank you, Nikita. You can tell how techno-competent I am.
Of course.
So,
No.
have you put it up already, or Nikita?
Just 1 second, and I
Yeah.
will put it up.
Just quickly, while Nikita's doing a couple things, I've been to about almost 200 Board of Health meetings for Tobacco 21, and really enjoyed working with a lot of people. And we are in quite a unique state where the boards of health, determine the destiny of the towns. And when you get enough towns, you can take it to the state level as well. So that's been pretty exciting. So I'm a pediatrician in practice. I've been in practice for 34 years now. And I want to talk a little bit about tobacco and COVID. Actually, it was and I call this the summation of inflammation. And before that, I noticed somebody asked about tobacco and chew. Chew is still legal, and correct me if I'm wrong, anyone, for unflavored plain tobacco. This is the one they're trying to get kids to use now, called Zyn, Z-Y-N. And this is a pouch-based device, and it's has nicotine but tobacco-free. And I believe this is okay to sell in stores at this point. Hopefully that'll change. Then the present thing that kids are trying to get hold of now are the puff bars. These colorful devices that you'll see out in the community. And finally, IQOS is the one that's coming out soon that they're going to try to replace Juul with, I think. Looks like a little cute cigarette with the device you put in, heat not burn, IQOS it's called, and that's the heat sticks you get with it. Anyway, so let's go on to the next slide here. Do I have the next slide there? So data's come out about, is COVID and smoking and vaping a problem? You know, the other thing on top of this is we have the e-cigarette vaping lung injury, which sometimes is getting kind of murky involved in this whole process, because we're not exactly sure. I was just reading about a 28-year-old who was oxygen dependent a month out from being in the ICU for COVID, and I am really curious if he vaped and don't know. But if you look at this chart, next chart, please, next slide, you can see that there's a 9 times greater chance of you have a history of smoking as having developed serious illness as those compared with no smoking. And I have little sayings down at the bottom, don't be a Juul fool, other things as well. Next. And then also smoking and vaping likely increases the severity of COVID by causing other morbidities like COPD, chronic obstructive pulmonary disease, or emphysema. And it's a huge risk factor in ending up in the ICU. And right now with COVID, if you're in the ICU, your mortality rate is about 70% if you're intubated. So the odds are not in your favor with that. Next. And then vaping and smoking suppress your body's defenses. The ciliaries, which are like the brooms in the lungs, are little tiny hairs that beat to bring up the mucus and bacteria, unfortunately get very discombobulated with e-cigarettes as well as smoking. So that leaves a lot of mucus down there. That's why you see nocturnal coughing or morning coughing, because they're trying to bring the junk up. It also impairs your first line of white blood cells and causes problems with stimulating these cells to fire up and cause inflammation because the chemicals are huge irritants within the lungs. Next slide. And then, interestingly enough, gene suppression. A toxicogeneticist showed me this very interesting study that showed they took 39 basically people, ones that didn't smoke, none that smoked regularly, self-described as cigarette smokers and self-described as cigarette users, and for at least 6 months. Dual users, which is the worst thing you can have, which big tobacco wants you to do, more than 5 cigarettes per week were excluded. Puff bars are poisonous. Little sidebar on that. Next. And when they compared the immune-related gene expression in the nasal mucosa of cigarettes and e-cigarette users, this was pretty scary. The extent of suppression of immune-related genes was 6-fold greater in e-cigarettes than in cigarettes in the nasal passage. Now, the nasal passage is somewhat similar to what goes on in the lungs as well. So, although it handles much more bacteria than the lungs do. So this is a very serious problem with e-cigarettes. And by the way, Juul does have in it vitamin E acetate. This was found out by the Koreans. So this was the product that people thought was causing the lung damage. And again, I think the lung damage we're seeing with vaping is being covered up by COVID at this point. Vaping may cause cavities. So anyway, next. So this is a real interesting point. And it's a bit of a complex process, but there's things called ACE receptors, which are angiotensin converting enzyme receptors. These are the receptors that affect your blood pressure. They are rich in the lungs, they're rich in people who are diabetic, and they're rich in people who are obese. And some people want to say in the African American population, just an excuse to call it genetics, particularly Representative Cassidy from my home state, Louisiana. And he's an internist that says, well, African Americans prone to this because they have more receptors. There's no proof of that. But what happens with nicotine is, and obesity and diabetes, it upregulates these receptors. Not only are these receptors where the angiotensin converting enzyme that regulates your blood pressure attached to a cell, particularly a lung cell in this case, it allows COVID viruses to enter into the lungs quicker. Henceforth, this is why we think that people who are addicted to nicotine, which upregulates this as well as tobacco, in other words, when upregulation means makes the cell membrane have more receptors for the ACE2 enzymes, and also the nicotine will do the same thing as well. So next. So, and then on top of this, there's flavors. We know menthol cigarettes cause severe inflammation in the lungs as compared to smoking non-flavored cigarette users. A very common flavor other than menthol is cinnamaldehyde, which is a common e-cigarette flavoring. It's like a cinnamon, and it's often put in multiple different types of flavorants. And these, suppress the function of the lung lining cells and inhibit the immune system to work as well. Not to also mention when they put it onto a plastic plate, when they were doing some work with blood plates with it, the cinnamaldehyde burned a hole through the plastic. So this is a pretty caustic substance that kids are putting in their lungs. And vanilla will do the same thing as well. Flavors hook kids. Next. So this is a little interesting thing that I learned about. We talk a lot about the intestinal microbiome, thinking, there's all sorts of good bacteria, and we end up sometimes making the bacteria bad by doing various things like eating junk food. Well, there's a connection in the microbiome that actually there is bacteria in the lungs. It's transient, but it actually can go in the lungs. And when people get like COPD, they get the picture of the lungs becomes somewhat similar to the pictures of the GI tract. And if you look to the left here of the probiotic type and prebiotic bacteria, you see that they'll pass through and they won't cause any inflammation in the cells, all right? But when you smoke, you start killing that off, or you vape. And what overgrows is strep pneumonia and Pseudomonas, which, as you can see, causes inflammation, triggers inflammation, and then triggers more inflammation from the neutrophils, the white cells, the macrophages, which eat up junk in the lungs, and what we call the dendritic cells. And in the middle there, you'll see IL-1, IL-2. Those are cytokines. And in case you may have heard about this, in COVID patients, there seems to be a secondary phase of lung disease that's not infectious but inflammatory, and will actually practically will destroy the lungs, and oftentimes people die of this. The big one on this is what you call IL-6, interleukin 6, tumor necrosing factor, and all the other fancy names there are with it. But these are the things that basically, during or just after a COVID infection, invade the lungs and destroy them, and that's the people that oftentimes get intubated. Kids don't seem to have an as active an immune system, so they're much less likely in this area, ironically, much less likely to have a cytokine storm. If you want to look it up, there's a real good quick review in Wikipedia on this if you'd like to learn a little more about the science. But I thought it was interesting that there is bacteria that comes and goes in the lungs, and it's seriously changed with vaping and smoking. Next. So how does the virus spread? Smokers and vapors. Smokers' coughs are more likely to have are more likely to infect people because they'll just be coughing on other people with the smoker's cough that probably spreads the germ more. And then what's even worse is the kids sharing the vape pens and repeatedly putting it in their mouth and handing it to somebody else. And unfortunately, many of them may be asymptomatic carriers, and they bring it to grandparents, social interaction with elderly people, maybe in a mall would cause this problem as well. And that's why kids need to wear masks as well, as far down as age 2. Next slide. All right. When they looked up the coronavirus MERS, there are 2 coronaviruses other than COVID-19. SARS, which was in China, that was contracted through civets, which are a cat-like animal in the marketplaces like in Wuhan, the wet marketplaces. And MERS, which was a camel one, apparently. And MERS, it was found to be independent, that smoking was an independent risk factor in developing serious MERS disease as well. So basically, vaping is horrible for your lungs in the first place, and it's even worse when somebody has COVID. And down the bottom it says lungs hate vitamin E acetate, which is thought to be the thing that's in e-juice, both in marijuana and in nicotine form. And I think this is it. Unfortunately, we didn't put in the slide about, did we put it? Oh yeah, the first slide. Did I show the first slide, second slide there with more Healy's handout? Because I know, Jamie, you asked me to do that.
You didn't, but we can share it with the group after.
Would you mind? It was supposed to have been in these slides, and I apologize. We had worked on this handout with the Attorney General and her group, which can be posted in schools and it can be handed out as well. It's a very colorful one. Thank you.
Thanks, Lester. At this time, I'm going to ask all the panelists to please turn on their computers so that we can get into some of the questions. Thank you to everyone that submitted questions in advance with your registration. Reminder, if you have any questions for the panel, please type them into either the chat box or the Q&A now. So I'm going to go ahead and get started. So how do we as providers successfully support teens and young adults in quitting smoking, vaping, THC with underlying anxiety disorders of which they are using the products to self-medicate? Lester, do you want to take this one?
Well, sure, I'm happy to. Certainly, there's an association between cigarettes, anxiety, and depression. We see kids, who get a buzz and get a little bit, quote unquote, high, especially with nicotine in vaping, because they have benzoic acid, which causes quick absorption of the nicotine that then gets a bigger head rush when they do it. And that gets them out for a little while of feeling anxious. And so as a result, the key that we try to do when we see patients with cessation issues, we like to look for what's called comorbidities. Is somebody depressed? Is somebody anxious? And what we find is sometimes these kids, they need cognitive behavioral therapy, CBT, and they may need medications as well to reduce the propensity to use these products. Now, we also encourage, even though the evidence isn't clear, and Dr. Levy at Children's is really working on this in the adolescent substance abuse program, is developing a vaping cessation program, because it's not clear the evidence yet that gum and patches and everything are that successful. Despite the fact we still continue to use, because there's no evidence-based guidelines yet.
Thanks, Lester. I think this
Yep.
next question will either be for Gwen or Ilana. What can we do to be advocating for tobacco legislation or regulation remotely during the COVID-19 crisis?
I'll take that one. So yes, there's actually a lot you can do. So you can reach out by email, you can call the office, you can talk, you can ask for an appointment with a staffer, a phone call with them, and talk about what you're seeing, and talk about the need. Again, at Tobacco Free Mass, our biggest push right now is funding for the tobacco control program. So, so to talk about what you're seeing and the need for, for whatever it is. If you are looking at anything that has to do with the tobacco control program, then please do talk about, why it's important to have the new laws enforced well, so the funding for the tobacco control program. If nothing else, just educating them about what you're seeing and keeping the issue alive in their mind is something that's a concern. It's really, really important because that will help everybody's efforts in tobacco. So, yes, so concrete things you can do: email, call, you can tag them on social media, any of those things. And if you're not sure who your legislators are right now, you can always go online and find out.
Thanks. And I think this next one is for Ilana. What can we be doing to support kids having conversations with their elected officials or with their parents about COVID-19 and vaping so that we can bring youth voice into the conversation?
Well, I'll weigh in, and Gwen may be able to supplement that answer too. I know that there are organized youth groups, and I might get the name wrong, it has 84 in it.
84. Mm-hmm.
And those are groups that really create a core of educated youth who are, interested and able to talk about the issues that they're confronted with, how it impacts them. They give a firsthand account. It can be very powerful for just, legislators and other decision makers, policymakers, to hear from youth what they're experiencing. And so working to help build that core and supporting it. And Gwen, you might have more specifics.
No, I think that's perfect. And if there is an 84 chapter in their area, they can join that. And if there isn't, they can start one. And they can always, of course, write or call their legislator anyway.
Great. We have one final question from Shannon Larson. Any thoughts on how to address student school suspensions due to students being caught vaping, and how to use education to inform school districts to offer diversion/education programs instead of suspensions? We offer a substance use diversion program at our MGH school-based health centers in Revere, and it has been successful.
Can you sort of explain what the question was? The question.
So I think the question is, what should we do about students who are being punished, mostly through suspensions, by being caught vaping? Are there any strategies that we can use to offer diversion or education programs?
I know that I've heard from different school districts, part of it might be educating the school districts, but there's been awareness that this isn't fruitful. This is something, it's an addiction, and if youth are suspended, then they may even be using more while they're outside of school. Then they come back into school and they're continue to be addicted, which means they're likely to be suspended again. So I know that school districts are approaching this by, instead of having out of school suspension, maybe in school educational programs, and working to actually defeat the addiction and working with the youth in that regard, rather than it being punitive. I think that it's a complicated issue, but I think the bottom line to the question, the answer is to try to approach it through education with school administrators so that they understand the ineffectiveness perhaps of chronic suspensions and expulsions.
And I'd also like to add to that, because I think you're absolutely right on, Ilana. A resource that I'm not sure that all the school districts know about is on the Department of Public Health's website under the Mass Tobacco Cessation and Prevention Program. They have, it's under GET, I think if you go to Get Outraged, you can find it, getoutraged.org. It's an excellent toolkit for schools. It has all sorts of educational pieces, but also some policy pieces in there. And they're sure to find at least some hints on for the right direction to move in, which is the one that Ilana was talking about.
Great. We'll make sure to share that with the group. I just want to be conscious of everyone's time. Thank you so much for joining us for this really important and interesting, timely conversation. We'll be sending around a follow-up email that includes the Attorney General's form that Lester was talking about, the toolkit that Gwen and Ilana were talking about, as well as a recording. Thank you all so much for joining us on this Wednesday, and I hope you have a safe and healthy rest of your week. Bye.
Bye.